Welcome to PRISM Rounds, the audio journal club, where we break down one study at a time for ICU, ED, and pulmonary/critical care teams, including physicians, trainees, nurses, pharmacists, and respiratory therapists. Each episode is designed for busy clinicians who want to understand not only the headline result, but also the clinical question, study design, key findings, limitations, and bedside relevance. The goal is to make new evidence easier to digest and more useful for real-world practice. Whether you are on service preparing for rounds, teaching learners, or simply trying to stay current. I originally started making these episodes to support my own learning and review. I am sharing them publicly in case they are helpful to other clinicians and learners who are trying to keep up with the growing critical care and pulmonary literature. Everything you hear is for educational purposes only and should not be taken as medical advice. Clinical decisions should always be made in the context of the individual patient, local practice standards, and the judgment of the treating clinical team.
Surviving the ICU is not the same as recovering from critical illness. This week on PRISM Rounds, we discuss iRehab, a JAMA trial, asking whether remote rehab after discharge can help ICU survivors rebuild strength, reduce fatigue and anxiety, and improve quality of life. The primary endpoint was neutral, but the story is richer than simply positive or negative.
Yeah, that is perfectly stated.
Right. So, welcome to the deep dive, everyone. If you are joining us today, chances are you have stood at the bedside, waved goodbye to a patient rolling out of the hospital in a wheelchair, and just felt that lingering sense of unease.
Absolutely, that pit in your stomach.
Exactly. We consider discharge this massive victory, and it is. But for the patient, it is often just the beginning of an incredibly steep hill.
Yeah, and I think that unease you mentioned is completely justified because when you work in critical care, it's really easy to get tunnel vision.
Oh, totally.
We pour immense resources into, getting a patient extubated, getting them off vasopressors, making sure they are hemodynamically stable. But the reality of post-ICU syndrome, or PICS, is honestly grim.
It really is. We don't see it because they leave our unit, but it's grim.
Right, because when these patients finally go home, their lives are often unrecognizable to them.
Mm-hmm.
I mean, they're dealing with profound critical illness, polyneuropathy, just overwhelming fatigue, cognitive deficits, and severe anxiety.
Yeah, the PTSD element is huge.
It is massive.
Yeah.
So the mission of our discussion today is really to figure out if we can actively bridge that terrifying gap between simply surviving the hospital and actually reclaiming a meaningful life at home.
Which brings us perfectly to the iRehab trial. Let's look at the blueprint of this intervention because building a recovery parachute for these patients is practically a logistical nightmare.
Yeah, an absolute nightmare.
Right. So they ran this pragmatic, multi-center, assessor-blinded, randomized clinical trial. And they did this across 52 National Health Service hospitals in the UK.
Which is incredible, honestly.
It is. Spanned from December 2022 to November 2025. I mean, coordinating a standardized rehab protocol across 52 different health trusts is a massive undertaking. But, it is exactly what you need to get that messy real-world data.
Yeah, it gives us a phenomenal footprint. And they enrolled 429 adult patients. The inclusion criteria were pretty straightforward, but they definitely selected for a deeply vulnerable population.
Yeah, walk us through who exactly these patients were.
So these were adults who survived critical illness and required invasive mechanical ventilation for at least 48 hours during their ICU stay.
Okay, so they were definitely sick. 2 days on the vent minimum.
Exactly. And they were randomized within 12 weeks of hospital discharge. So 231 were assigned to the remote rehab intervention, and 198 went to standard care.
Okay, so I want to dig into the actual mechanics of that intervention because, remote rehab sounds great on a slide deck at a conference.
Right, it sounds very sleek.
Yeah, but how does it actually work for a patient who gets completely winded just sitting up in bed?
Yeah.
Like, we are talking about a 6-week remote individualized program, and the key word the investigators use is multicomponent.
Right, which is crucial here.
Because they weren't just mailing a Xerox sheet of stretching exercises to someone's house and saying good luck.
No, far from it. The intervention was designed to tackle both the physical and the psychological devastation of PICS. So it included weekly symptom management, targeted exercise and physical activity, psychological well-being support, peer support, and education.
Wow, so a lot of different touch points.
A ton of touch points.
Yeah.
And it was delivered entirely remotely, so via online video platforms or, honestly, simply over the telephone.
Okay, that makes it more accessible, just a phone call.
Exactly. And it was led by trained intervention specialists. But those specialists were backed by a really robust, multi-professional team. We are talking physiotherapists, occupational therapists, dietitians, and clinical psychologists.
It sounds incredibly comprehensive. I mean, it really does. But here's the tension for me.
Okay, let's hear.
Our current standard of care, just standard hospital discharge, it often feels like pushing a patient out of an airplane without checking their parachute.
Oh, that is a dark analogy, but it's very accurate.
Right, because we spend weeks managing their ARDs, titrating their PEEP, fighting off ventilator-associated pneumonias. We get them through the absolute hardest part, and then we just kind of wave goodbye as they fall into the community.
Yeah, we just hope they land softly.
Exactly. So the fundamental question this trial poses is this. Is a 6-week remote program, delivered through a phone or a video screen, is that robust enough to act as that parachute? Or is it simply too little, too late for a body completely ravaged by critical illness?
Well, to determine if that parachute actually deployed successfully, we have to scrutinize the gauge the investigators used to measure the landing.
Okay, what was the primary endpoint?
They chose a tool called the EQ5D5 utility score to assess health-related quality of life, and they looked at this at 8 weeks.
Okay, EQ5D5L. I always approach these generic quality of life surveys with a bit of caution, honestly.
Yeah, you and me both.
Because the EQ5D5L, it measures 5 dimensions, right? Mobility, self-care, usual activities, pain or discomfort, and anxiety or depression.
Right, those are the 5.
It's just such a broad net. And for a trial like this, they set a pre-specified minimum clinically important difference, the MCID, at 0.08.
Yep, 0.08 was the target.
So basically, the intervention had to improve the score by at least 0.08 to prove it was truly changing patients' lives in a tangible way.
And that is a high bar for a generic survey. I mean, when we look at the primary endpoint, the trial was neutral.
Neutral. Okay, let's hear the numbers.
At 8 weeks, the EQ5D5L utility score was 0.69 in the intervention group versus 0.67 in the standard care group.
Oh, so barely any different.
Barely. The adjusted mean difference was only 0.04. The 95% confidence interval ranged from minus 0.001 to 0.09, and P equals 0.05.
Wow. P equals 0.05, right on the line.
Right on the line. But most importantly, that difference of 0.04 fell well short of the 0.08 threshold required to declare a clinically meaningful victory.
So here is where we really have to look critically at the trial design, I think. We built this comprehensive parachute, but the data says they still hit the ground too hard.
Yeah, the landing was rough.
But I have to wonder if we were simply looking at the wrong gauge. Think about the patients you treat in the unit. If you are an ICU survivor who just spent 6 weeks learning how to stand up from the toilet without desaturating,
Which is a massive win for them.
a huge win. But does a generic survey about, quote, usual activities effectively capture that monumental recovery? It forces a really tough question. Did the trial fail the patients, or did the measurement tool fail the trial?
I strongly lean toward the latter, and the secondary outcomes strongly support that skepticism.
Yeah.
Oh, absolutely. This is precisely why we cannot stamp this trial with a simple negative label and just move on.
Right, because the primary was neutral, not the whole thing.
Exactly. When you look at the granular, patient-centered metrics, the secondary signals, a much richer story emerges about how recovery actually happens.
Right, because when you look at the specific domains patients actually care about, the intervention clearly did something.
It did. Let's talk about physical function. They looked at that using the 30-second sit-to-stand test.
Oh, that is a brutal test of core strength and balance.
It is. It really tests their independence. And the remote rehab group performed significantly better on it.
That alone is huge for preventing readmissions from falls.
Completely. And they also saw vital improvements in fatigue and anxiety. So for fatigue, they used the SCTF scale. And for psychological distress, they used the HADS score. Both showed meaningful improvement in the intervention arm.
That's fantastic.
And furthermore, the patients who actually did the program found it highly acceptable.
You know, those specific metrics are so important to me. I really appreciate when trials use the SCTF because it doesn't just ask, are you tired?
Right, everyone is tired.
Exactly, we're all tired. But it measures functional fatigue. It asks if your exhaustion actively prevents you from doing normal things, like making a meal or holding a conversation.
Yes, exactly.
And the HADS score, the Hospital Anxiety and Depression Scale, It captures the crushing PTSD that so many of our survivors battle. I mean, these are the exact complaints patients bring to the post-ICU clinic.
Yeah, you hit the nail on the head. And there's also a really fascinating temporal signal here that we have to talk about.
Okay, what happened over time?
At 6 months out, the primary outcome, that generic EQ5D5L score, actually did shift in favor of the intervention.
Wait, at 6 months it was positive?
Yes. The adjusted mean difference hit 0.08 with a 95% confidence interval of 0.03 to 0.13.
Oh, wow. So it finally hit the MCID threshold.
It did. Now, we have to treat that as hypothesis generating, of course, since the trial was powered for the 8-week mark. But it strongly suggests that the physiological and psychological benefits of rehab, they compound over time.
Yeah, it takes way longer than 8 weeks to rebuild a human being from scratch.
Exactly. The accompanying editorial for this trial frames this beautifully, actually.
What did the editorial say?
The authors emphasize that high-quality survival means function, it means participation, and actual recovery, not just having a heartbeat.
Right, surviving versus living.
Exactly. Rehab is a deeply complex intervention targeting physical, psychological, and social domains all simultaneously. So relying on one generic outcome is it's like trying to measure the success of a symphony by only listening to the percussion section. You miss the true effects.
That is a great way to put it. It is a classic mismatch between the tool and the treatment.
Yeah.
When you deploy a multifaceted intervention, you just have to analyze the pattern of outcomes across multiple systems. It is the difference between using a blunt instrument and a scalpel.
I like that.
Right. That primary endpoint, the generic quality of life survey, was a blunt instrument that just completely missed the mark. But those secondary outcomes, the sit-to-stand test, the FACIT-F, the HADS score, those are the scalpel.
Yes, absolutely.
They cut through the noise and they show real, tangible clinical gains. So for the clinician standing at the bedside tomorrow, how do you weigh these secondary scalpel signals to justify fighting for rehab when the blunt primary trial is technically neutral?
Well, I think you justify by recognizing the heterogeneity of critical illness. I mean, you know this. Not all ICU survivors are the same.
Not at all.
And the recovery trajectories are completely different. So if the intervention showed all these granular benefits, why were the overall primary numbers diluted?
Right. What brought the average down?
The investigators answered this by looking at 8 priority subgroups based on the duration of mechanical ventilation. And the biological divergence here is striking.
Oh, this is the most compelling part of the data for me. How did the amount of time on the vent change the patient's response to the rehab?
So they divided the cohort into 2 groups. Those with shorter ventilation, which they defined as 7 days or less, and those with longer ventilation, meaning more than 7 days.
Okay, makes sense.
For the patients ventilated for 7 days or less, the remote rehab was highly effective. They saw better primary outcome scores, achieving an adjusted mean difference of 0.10.
Wow. So that not only meets, but it actually exceeds the trial's clinically meaningful target of 0.08.
Exactly.
So for the shorter ventilation group, the parachute deployed perfectly, the intervention clearly worked. But what happened to the patients who were on the vent for more than a week?
This is where it gets tough. For the prolonged ventilation group, the intervention's effect on the primary outcome was virtually zero.
Zero.
The adjusted mean difference was minus 0.01. So the 6-week remote program did absolutely nothing to improve their broad quality of life at 8 weeks.
Man. The clinical logic there is unavoidable when you think about the pathophysiology of deconditioning.
Yeah, it really highlights how devastating the vent can be.
It does, because after 7 days on a ventilator, you are dealing with profound diaphragmatic atrophy, severe muscle wasting, and deeply entrenched critical illness polyneuropathy.
Oh, and muscles just melt away.
Literally. You wouldn't prescribe a casual 5K runner's physical therapy plan to a patient who just underwent bilateral joint replacements.
No, of course not.
It makes me think our future standard of care needs a total paradigm shift. Should we be prescribing rehab intensity exactly the way we titrate vasopressors in the ICU?
That's a fascinating way to think about it.
Right. We need to match the exact dose, the duration, and the modality of rehab to the severity of the patient's critical illness.
Yes, and that is the exact clinical interpretation you should take back to your practice. A universal, one-size-fits-all 6-week pathway is destined to fail the sickest patients.
It just isn't enough dose.
Right. Prolonged mechanical ventilation is one of our most well-established predictors of long-term morbidity. Survivors in that category, they don't just need a phone call.
Yeah, a phone call won't fix myopathy.
Exactly. They likely require highly intensive, prolonged, in-person, facility-supported rehabilitation to make any meaningful gains. For them, a remote program is just a drop in the bucket against their level of deconditioning.
To put the severity of that deconditioning into perspective, I noticed the editorial pointed out something really sobering.
What was that?
Even at 6 months out, the sit-to-stand scores for these prolonged ventilation patients were still far below the functional threshold required for community-based independence.
Wow.
Yeah, they're still functionally grounded half a year later.
Which illustrates precisely why tailoring the recovery pathway is non-negotiable. However, and this is a big however, even if we develop perfectly tailored, phenotype-specific rehab protocols, we still have to confront the massive real-world barrier of implementation.
Ah, right, actually getting them to do it.
Exactly. Can we actually get patients to do this?
Let's talk about the attrition numbers, because implementing this at scale isn't just about the biology of muscle recovery, you know? It is about human behavior, healthcare access, and just cognitive load.
Yeah, the refusal rate in this trial is a glaring limitation that we have to discuss.
It was high, wasn't it?
It was astronomically high. Out of 1,672 eligible individuals who were offered participation, a staggering 1,109 declined.
Wait, 1109.
Yes, that is a 66% refusal rate for an intervention that they could literally do from their own home.
I have to pause on that number because it is staggering. 2/3 of the eligible patients walked away.
Yep.
If this is remote and you can literally do it from your living room via a smartphone, why did so many people say no? I mean, are we offering this at the wrong point in their recovery timeline? Or is the cognitive and mental burden of just one more medical appointment simply too heavy for our survivors?
It is almost certainly a combination of all of the above. I mean, the promise of remote rehab is that it removes the travel burden, right? You don't have to find a ride to the clinics.
Which is usually the biggest barrier.
Right, but it uncovers entirely new access
Yes.
barriers. You have to account for patients with severe physical disabilities who literally can't hold a tablet, or they have poor access to reliable internet, or low health literacy.
Good point. Tech isn't easy for everyone.
No, it's not. But above all, you have to account for the profound, bone-deep exhaustion of prolonged critical illness. When you are at home, struggling to manage your oxygen tubing, sorting through a dozen new pill bottles, and getting winded just trying to eat breakfast.
The idea of a Zoom call is horrifying.
Exactly. The idea of logging onto a video call to do exercises feels completely insurmountable.
Yeah, picture a patient you just discharged last month. They spent 2 weeks on the vent. They are finally home. If we call them on week 2 and say, hey, we need you to log onto this platform for an hour of targeted physical and psychological therapy, it feels like an assault on whatever tiny bit of peace they've found.
It really does.
And this brings up a major concern about the generalizability of the trial. The 1/3 of patients who actually did consent to the trial, they might represent a highly specific subset of survivors.
Oh, definitely.
They might be naturally more motivated, or perhaps they had a slightly higher baseline of functional reserve compared to the massive majority who declined.
Yeah, that selection bias absolutely limits how broadly we can apply these findings. The trial proves that remote rehab is highly acceptable and effective for those who actually engage with it.
Right. If you do it, it works.
Exactly. The fidelity and adherence among the participants were excellent, but getting the broader population of survivors through that virtual front door is a massive, unsolved hurdle.
So synthesizing the design, the granular scalpel signals, the biological subgroups, and the massive attrition rate, where does this leave us clinically?
Well, 6 weeks of remote rehab did not clearly improve short-term, generic quality of life for all ICU survivors. But it undeniably improves specific functional domains that dictate a patient's independence. Things like core strength, fatigue, anxiety, and self-management skills.
Which is what really matters.
Right. The overarching lesson is that recovery programs must be flexible, scalable, and tailored to the survivor's specific phenotype. A patient who is ventilated for 4 days requires a completely different recovery architecture than a patient who was ventilated for 14 days.
Discharge is not the finish line. Remote rehab is promising, scalable, and acceptable, but iRehab did not clearly improve 8-week quality of life for all ICU survivors. The future is matching intensity, timing, and modality to recovery trajectory.
That perfectly captures the reality at the bedside. And to leave you with a final thought, to mull over building on that massive 66% refusal rate, what if the greatest hurdle to post-ICU recovery isn't actually physical, but psychological identity?
Ooh, psychological identity. I like that.
Think about it. Patients who decline follow-up care often have inherently low expectations for their full health recovery. During their prolonged hospital stay, they have deeply internalized the identity of being chronically ill, frail, and dependent.
That becomes who they are.
Exactly. Perhaps the next great frontier in critical care isn't just designing better physical exercises, but finding ways to psychologically convince frail survivors that they are still capable of rebuilding their strength. We have to figure out how to reframe rehabilitation in their minds, not as just another medical burden imposed by the hospital, but as a powerful, active reclaiming of their independence.
Wow. A profound shift in perspective to end on. If we can change their mindset, we might actually change their outcome. Thanks for listening to PRISM Rounds. Follow or subscribe for more clinically grounded discussions of new evidence in pulmonary, critical care, and emergency medicine.
Thank you for spending your time with PRISM Rounds. If this episode helped you think through the paper or offered something practical for the bedside, I'd be grateful if you'd like, follow/subscribe, and share it with a colleague. It's the simplest way to help this resource reach other busy clinicians and learners. I'm also trying to make the podcast better with every episode. Please leave a comment with what you found most useful, what felt unclear or too long, and what topics or papers you'd like covered next. If there's anything I can do to improve, pacing, structure, level of detail, or audio quality, I genuinely welcome the feedback. Thanks again for listening, and take care. Educational use only. This is not medical advice.